Dear friends, as you're aware, I have been conducting the workshops and CMEs for the lung function for last almost 30 years. What I found was that people were little not comfortable with subjects like diffusion capacity or body plasmography. But lately I have seen that the doctors are asking about oscillometry. They do not know when to do it, how to interpret this. So I thought let us make it simple to understand. In this video, I'll try to make oscillometry a very easy subject to learn and how to do it, how to interpret this, all these aspects I'll be covering in this video. So I'll be talking about the oscillometry in clinical practice. And this is my email address, which you can note, and my mobile number. In case you have any difficulty or any query you have, you can always contact. You see, when compared with the spirometry, we find oscillometry is easier to perform as it requires only normal tidal breathing. It can be easily performed by the children, elderly, and those who find spirometry difficult to perform because spirometry needs cooperation of the patient and effort by the patient. It gives additional information than what the spirometry does, and it is more sensitive than spirometry, especially for small airway obstruction. However, there are some disadvantages, like in oscillometry, the coefficient of variation is up to 10% in adults and up to 15% in children, it is acceptable. And while in the spirometry, we accepted only up to 3%. And there are also lack of reference values. Only few reference values are available. So there is another constraint with the oscillometry. Du Bois was the person who talked about the body plasmography in 1956. He described the force oscillation technique for oscillometry which we use today, again in the same year. When you look at look at this picture, the size of the machine at that time was this big, and now the size after some time the size came down to the desktop model, and currently it is the handheld model through which we can do the oscillometry. So there has been change in the size also, and it has made it very easy. Now, in this case, the basic principle is we are using the sound waves. If you look at the sound waves, they are used to communicate and to enjoy the music. The bats, they find their prey and they find their direction through the sound waves. We also know that ships, they use sounds to find the depth of the sea. And about the medical use of sound, we are all very well aware of. So if you understand the principle of oscillometry, basically in this, the sound waves which act as the pressure waves, they are delivered to the respiratory system. They are superimposed on the normal tidal breathing, and impedance is the force which is offered by the respiratory system, which is measured. If you must be hearing too, that is the FOT and the impulse oscillometry. Basically, impulse oscillometry is a type of force oscillation technique that is called FOT. In the FOT, you find the sinusoidal waves are there in the oscillometry. These are and main difference is it is only one frequency is sent at one time. It provides a good time resolution with the measures of respiratory resistance, and it is cheaper also. While when you look at the impulse oscillometry, here the multiple sound frequencies are sent at one time, and they are square waves, and it can calculate the impedance at any frequency between 5 to 30 hertz. It has improved signal to noise ratio, and it takes slightly less time than the FOT, but slightly more difficult discomfort to the patient. Also, we need to know that in iOS, the frequencies are multiples of 5, that is 5, 10, 15, 20, and all. There is overlapping, so the noise is increased. However, if you use the prime numbers like 5, 7, 11, 19, then there is a minimum signal to noise ratio. So impedance, as we discussed, is the total force required to propagate a pressure wave through the pulmonary system. And all of these chest wall, lower pharynx, large central airways, small airways, parenchyma, they all contribute to this impedance. And impedance has two components, that is resistance and reactance. Airway resistance is basically it is the pressure which is required to produce an airflow in and out of the lungs. So if the pressure has to be more, that means there is more resistance. If lesser pressure is required, that means there is a lesser resistance. And what about the reactance? Reactance basically reflects how easy it is for the air to reach the peripheral small airways or the distal areas of the lung, and reactance becomes more negative in the diseases which are affecting the small airways. The reactance reflects inertance and capacitance properties of the respiratory tract. In inertance, it reflects the acceleration of the gas or sometimes lung mass in the central airways, while capacitance, it indicates elastance and compliance. Elastance, basically, if you take the example of the new socks, when you stretch it, you leave it, immediately it comes back to normal. But when it becomes old, if you stretch it, it does not come back to normal so easily. So that means the elasticity is reduced. That is in simple term elastance. Then compliance, you see, there are two kind of balloons. One balloon where you push with the minimum force and it swells up. While in the another balloon, you have to really give more pressure to inflate it. So the first balloon is more compliant. That is, any change in the pressure will produce more change in the volume. While in the second situation, when it is difficult to be inflated, that means it has lesser compliance. So what we notice that in the normal lungs, they will have normal compliance and normal elastance. In COPD, the compliance is increased, that is, the opening up of the air spaces is easier with the minimum pressure, while elastance is reduced. While in interstitial lung diseases, the compliance is reduced, but the elastance is increased. Coming back to the impedance, you see, so far what we have discussed is that impedance has two components, resistance and reactance. Resistance is the pressure required to generate a particular flow. Reactance is related to the volume change, that is, it has two components, inertance and capacitance. And capacitance has two components, elastance and compliance. With this background, let us see the frequency of the sound waves and the airway calibers. You know, we have the larger airways up to 7th generation bronchi, and 8th generation onward, we have the smaller airways, which are less than 2 millimeters in size. The higher frequencies, like 20 Hertz, they travel only up to the larger airways, and the low frequencies, like 5 Hertz, they travel right up to the smaller airways, that is periphery of the lung. And if you find that the difference between the resistance at 5 Hertz and 20 Hertz, if it is increased, it indicates that the small airways are closed. And also small airways abnormality, we need to know that it occurs much earlier before the onset of symptoms, or the spirometry is abnormal, and that's why it is called the silent zone. An increased R5 minus R20 suggests small airway closure, and it helps in the detection of small airway disease. So, like, take the example of a music concert. You know, the notes sa, re, ga, ma, pa, dha, ni, sa. In this, the frequency of the note is increasing as you move from sa, re to the dha, ni. So, sa has the lowest frequency, ni has the highest frequency. Now, in the musical concert, what happens? In the front seats, you can hear all the frequencies. But in the back seat, because higher frequencies, that is dha, ni, they cannot travel up to the periphery, they may not be heard clearly. And you see, that is the reason that the true music lovers, they pay more for the front seats. Although we feel that what is the difference between the front seat and the back seat, but they pay more so that they can hear all the frequencies. Coming to the procedure of the oscillometry, patient is made to sit in sitting position with the head in the neutral position or slightly extended. Flexion of the head is to be avoided. Mouthpiece is kept between the teeth and the lips, they are sealed around. The hands should be on the cheeks firmly so that there is no vibration once the person is breathing. A nose clip is put on the nose. And basically, we need 3 to 5 regular diver breaths, which are usually completed in 30 to 60 seconds. In case we have to do spirometry also, then we should do first oscillometry and then do the spirometry. And there should be a gap of around 3 minutes or so. We also need to understand that there might be some artifacts like coughing, glottic closure, swallowing, tongue obstruction. irregular reward breathing, leaks around the filter. So most of the time the software is able to take care of them, but we need to see that these things do not disturb our recording. Then there is a concept of Z-score, which many people are not clear. So I'll make it simple. You see, fifth percentile, it corresponds to the lower limit of normal called LLN, and the 95th percentile, it corresponds to the upper limit of normal, that is called ULN. Now, this so-called fifth percentile, it corresponds to Z-score of minus 1.645, that is less than this, that is abnormal. While 95th percentile, it corresponds to plus 1.645 standard deviation, that is plus 1.645 Z-score. So, simply values which are below minus 1.645 Z-score will be abnormal, they will be low. And values which are more than plus 1.645 Z-score, they will be taken as abnormal. In the example on the right side, if you see here, the Z-score is 3.02, which is more than plus 1.645. That means it is increased. So resistance is increased. While if you see the reactance value, here the Z-score is minus 2.06, which indicates that is more negative. That means again it is increased. There is something called covariance. Basically, it determines the artifacts between the flow and the pressure at each frequency. It also tells us the quality of the test which is done. So here what we do, we take only the artifact-free portion of the measurement, and we do 3 technically acceptable measurements, and here mean is taken. In spirometry, we take the highest value, here mean is taken. And we say that the effort is acceptable. For this, the co should be less than 10% in adults, while it should be less than 15% in children. Now, if you see this example, you see these are the 3 readings, and mean of the reading is taken as 5.95, and below this you find 2.96. Basically, this is the co, which indicates that yes, it is less than 10%. So the quality of the text is ensured. Now, coming to the interpretation of oscillometry, that was the background. Now we come to the interpretation. So you have this parameter Z, that is the total lung impedance, resistance plus reactance. Then you have the resistance R at 5 Hz, and then you have the resistance at 20 Hz, that is R20. And the difference between R5 and R20, this indicates resistance in the smaller airway. So R5 indicates resistance in the entire respiratory tract, while the R20 indicates the resistance in the larger airway, and difference as resistance in the small airway. Now this line is the reactance, line of reactance. And here, if you see, the upper portion is inertance and the lower portion is the, in this case, the capacitance. So in X5, this is the X5, this indicates reactance at 5 Hz. And this X5 represents small airway obstruction, lung elastin, lung compliance, and lung heterogeneity. And then we have something called reference, that is resonant frequency. Basically, it is the frequency at which the reactance becomes 0. Inertance and capacitance are same, they are in the opposite direction. So the reactance here at this frequency becomes 0. And this indicates air flow obstruction and the lung restriction. And then we have this portion, that is the area of reactance. So the Goldman triangle who describes this. And this is the reactance between 5 Hz and the FRS frequency. And what does it tell us? It tells us what is happening in the distal portion of the lung, both in the small airways and the lung parenchyma. And if you find the reactance inspiratory is more than the expiratory, it suggests restrictive lung function. While if you find the expiratory reactance is more than the inspiratory, then it indicates obstructive airway. So coming to the interpretation of the oscillometry graph, you will see how simple it is. So this is the typical output of the oscillometry procedure. So here you find this is the predicted value and this is the upper limit of normal. So if you find resistance is below this upper limit of normal, that means it is normal. If it is more, then it is increased. Reactance is usually negative. So this is the lower limit of normal and this is predicted value. If the reactance is lower than this, then we say the reactance is more negative or it is increased. So here the Z score will be plus 1.645 and here the Z score will be minus 1.645. Anything below this will be abnormal. Now when you look at this, you see it's very, very important. So this is the black line which indicates upper limit of normal this mustard line indicates resistance. So this is resistance at 5 Hz and this is resistance at 20 Hz. And here this black line is the lower limit of normal and this purple line it indicates the reactance. So this is reactance at 5 Hz, reactance at 19 Hz. That is, this indicates F also. And if the test is normal, then these resistance and reactance they should be within the normal range. Now let us have a look at this. So this is the upper limit of normal black line, but now you find resistance at 5 Hz and resistance at 19 Hz, both are increased. And also the difference between R5 and R19 is normal. So this is the observation in this. Now we look at the reactance. You find reactance is just overlying the normal values, that is over the black line. So that means all the three values, that is X5, the F this frequency, and the area of reactance, they are within the normal limits. So oscillometry in this case will be suggesting a large airway obstruction because R19 is also high. So in the reporting you will have R5 increase, R20 increase, R5 minus R20 is normal, X5, AX and FRS are all normal, which indicates large airway obstruction. Now just see this graph. R5 is increased, the R19 is below the black line, that means it is normal, and difference between R5 and R19, that is increased. Now the reactance lines you find X5, this is increased, the FRS it will be meeting here, FRS is increased, and of course the area of reactance, this is also increased. So in this situation, this will indicate small airway obstruction as R19 is normal. So here you will have R5 increase, R20 normal, R5 minus 20 increase, X5 is more negative, AX and FRS are increased. So this indicates peripheral small airway obstruction. Now just see this graph. So here you are finding R5 is increased, R19 is also increased, both are above the black line, plus R5 minus R19, that is also increased, as you can see here. Coming to the reactance, this X5 is more negative, the FRS will be increased, as we will be touching here, and the area of reactance, that is also increased. So you will find all the three parameters are increased. So in this situation, you will be diagnosing a small plus large airway obstruction because R19 is also increased, R5 is also increased. So in the table, you will see R5 is increased, 20 is increased, R5 minus 20 is increased. All the three parameters are increased. So this indicates large and small airway obstruction. Now let us have a look at this graph. So you find this is the normal black line and R5 is within the normal range, R19 is within the normal range, and R5 minus 19 is also within the normal range. But when you see the reactance line, the X5 is more negative, FRS is increased, and the area of reactance is also increased. So here, practically resistance is normal, and this is suggestive of restrictive pattern. So in the table, if you see, the R5 is normal, 20 is normal, R5 minus 20 is normal, but all these parameters are increased, which suggests the restrictive line. And this is the final table. If you remember this, you can diagnose most of the chest conditions. Now with this background, let's go down to some case exercises. So in this case, what you are noticing is that R5, R19 both are below this black line, that is, they are normal. And difference between R5 and R19 is also normal. When you look at the reactance, here also, the reactance line is within the black. That is, again, it is within the normal limit. So both the resistance and reactance are within the normal range. So that means it is normal oscillometry. And if you see the values also, as per the Z score, all the values are within 1.615. So that again indicates normal. And if you look at the graph carefully, you may not even need to see the values. Now in this graph, what you are noticing, R5 is increased, R19 is also increased, but R5 minus 19 is within the normal range, and reactance is just overlying this, the black line, which is normal. So that means X5 will be normal, FRS will be normal, and area of reactance will be normal. So that's what we are seeing here. And this will indicate, as we have discussed, large airway obstruction. And when you see the values, the R5, R19, they are in more than 1.6 or 5. Rest all are within normal, which is indicating large airway obstruction. Let us see this case. This is a case of post TB sequelae, and spirometry was done. And always look at the graph first, it is acceptable. So we go to the values. You will find FE1 is reduced, FEC is mildly reduced, and the ratio is much reduced. So there is a severe obstruction with mildly reduced vital capacity. And MES 50, that is maximum expirative flow, is 50% of vital capacity. That is just 15%, indicating severe small airway closure. And when the oscillometry was done, you see the R5 resistance is more than the upper limit of normal, so it is increased. X5 is lower than the lower limit of normal, that is again, it is more negative. And when you see the graph, you will find R5 is increased, R19 is increased, and the difference between 5 and 19, there it is also increased. When you see the reactance line, the X5 is more negative, F rest will be more, and the area of reactance, that will also be more. So in these cases, as we discussed, what do you feel? This is suggestive of small and large airway obstruction. You look at the values, again, you will find Z score is increased in all the parameters, which is typical of small and large airway obstruction. And you must be noticing, you see, even if you don't see the figures, by looking at the graph itself, you can diagnose what I am doing. Another case, this person had gradually progressive dyspnea for last 1 year. Also had dry cough for 1 year, clubbing was present, and examination revealed bilateral basal crepitation. So clinically diagnosed as a case of interstitial lung disease. And the spirometry was done. And again, look at the graph first. The graphs are both normal, flow volume as well as the time. And when you look at the values, you find the FVC and FEV1 both are reduced, and the MES 50, that is within normal limits. So what does it indicate is that there is a restrictive pattern, no obstruction, and the MES 50 is within normal limits, indicating that the small airways are also not closed. Look at the graph now. So the R5 and R19, they are below the black line, that is, they are within the normal range. R5 minus R19 is also normal. This is regarding the resistance part. And the reactance X5 is more negative, F rest is increased, and the area of reactance is also increased. So as we work, more restrictive pattern. And when you look at the values, again you find R values are all within normal limits, while X5, F rest, and AX, they are all abnormal. They are abnormally high. X5 is more negative, that means it is high. So this is all suggestive of restrictive pattern. Let's have a look at this. So the R5 is within normal limits, R19 is within normal limits, R5 minus 19 is also normal. But when you look at the reactance part, the X5 is more negative, the F rest will be increased, and the area of reactance will also be increased. So these are the findings, that the resistance parameters are normal, but reactance parameters are all increased. So again, this will indicate restrictive pattern. And when you look at the values, again, the resistance pattern, the Z score is less than 1.645, while the reactance part all are increased. Let us see the response to bronchodilator in cases of oscillometry. So this is pre-bronchodilator. R5 you find is increased, R19 is also high, and R5 minus R19 is increased. So that's what you have for the resistance. And coming to the reactance part, you find the X5 is more negative, F rest will be somewhere here increased, and the area of reactance is also increased. So as we have discussed, when all the parameters are increased, this is suggestive of small and large airway obstruction. And of the post-bronchodilator, you find the R5, R19 are below the black lines. That means they are all within normal limit. And even reactance line is within this black line. That means the reactance is also normal. So all the parameters have become normal post-bronchodilator. So this indicates no small or no large airway obstruction. If you compare, this was the pre and this was the post. So between pre and post, the percentage change in R5, there is a change of 59%. In X5, there is a improvement in 88%, And in AX, that is area of reactance, there is a improvement by 96%. And conventionally, it is said when the R5 improves by 40%, X5 improves by 50%, and AX improves by more than 80%, then we say bronchodilator responsiveness is present. And in a recent article in the European Respiratory Journal, it has defined that the minus 32%, that is reduction in resistance by 32%, or increase in the reactance by 44% change. So that indicates that there is a bronchodilator reversibility is present, or bronchodilator response is present. So let us see one or two cases where we found spirometry was normal, but the oscillometry was abnormal. So these are the cases where patient presented with episodic restlessness since childhood. There was history of episodes of repeated sneezing since childhood, and currently patient is almost normal, no specific symptoms. An examination revealed bilateral wheeze only on the force exhalation. So spirometry was done, the graphs were acceptable, and here what you find is FVC is normal, FEV1 is normal, the ratio is also normal, and MEF 50 is also normal. So that means no obstruction, no restriction, and MEF is also within normal limit. If you look at the graph now, the R5 is above the black line, so R5 is increased. R19 is within the normal limits, and this is below the upper limit of normal. And R5 minus R20 is increased. Look at the reactance. So X5 is more negative, FRS is increased, and area of reactance is also increased. So typically, as we had discussed in this finding, we will have the small airway obstruction, as R19 is within normal. So here, even if you look at the values, the R5 is more than 1.645, R5 minus 19 is also increased, but R19 is normal. And these parameters, X5, FRS, they are also increased. So this oscillometry is suggesting the small airway obstruction, which was missed by spirometry if we did not do the oscillometry. And you know, these people who have the small airway obstruction, they are called SAD asthma, that is small airway disease asthma. And it is important that in these persons, the microfine particles in the inhaled corticosteroids, like beclomethasone and cyclosinide, they are specifically beneficial for the small airway in asthma. So we need to remember this. Then another example where spirometry was normal, but the oscillometry was abnormal. This was a smoker for last 7 years, 7 back years. Occasional cough he had, came for the routine checkups, and this examination was within normal limits, and the spirometry was done. To find the graphs are acceptable. The FVC is normal, FEV1 is normal, the ratio is normal, and the MEF 50 is also normal, indicating there is no obstruction, restriction, and MEF 50 is also within normal. And when we look at the oscillometry, the R5 is increased above the black line, R19 is within normal range, and R5 minus 19 is increased. Look at the reactance, X5 is increased, FRS is increased, while the area of reactance is increased. So you find all the parameters are increased except R19. So again, it indicates small airway obstruction. When you look at the values, again you find that R5, R5 minus 19 are increased, R19 is within normal limits, and X5, FRS, and AX, they are all increased. Again indicating that this person had small airway disease, which was missed by spirometry. So the take-home messages, dear friends, is that the oscillometry is simple, effort independent, and patient-friendly, and it is useful across all ages, which include children, which include elderly. It detects small airway disease earlier than the spirometry or before the symptoms start, and it complements the spirometry but does not replace it. As many people say to replace spirometry, no, it complements spirometry, and when both are done together, it provides a complete evaluation of the lung function. So it's a future-ready tool, and it is expected, it's almost there to become part of the routine lung function testing. So please remember, oscillometry is not just a research tool now, it is ready for everyday clinical practice. Thank you very much, and I'm sure that by going through this video, you should be able to interpret the oscillometry findings in a very easy way, and there should not be any hitch, and you will start using oscillometry in your clinical practice. Thank you.